Our next program, the guest lecture on microvascular angina. May I now cordially invite the chairpersons, Dr. Prasad Sirivardhana and Dr. Mayurudhan, to introduce our speaker. Thank you.
Hi, I'm Dr. Prasad Sirivardhana, my co-chair, Dr. Mayurudhan. Next speaker is Prof. Kishor. He is a medical director, Central Delhi Diabetic Center, and Secretary General and IPF, Global Ambassador for Innovative Physicians Forum, India. And he's going to speak to us microvascular angina. Over to you.
Good afternoon, ladies and gentlemen. Thank you, chairpersons. I would like to extend my heartfelt thanks to Sri Lanka College of Internal Medicine, President Dr. Kumudni, President-elect Dr. Suranga, all members of the Executive Council for inviting me to deliver this important talk on this 7th Annual Congress of Sri Lanka College of Internal Medicine. In the next 15 to 17 minutes, we will discuss about the microvascular angina. We all know about what microvascular angina is. Originally proposed by Cannon and Epstein in 1988. It's used for angina, myocardial ischemia, which is attributable to the coronary microvascular dysfunction. And it is also sometimes called cardiac syndrome X. Patients with chest pain without obstructive coronary artery disease, they have been a diagnostic and a therapeutic challenge and have contributed to significant economic, social, and healthcare costs on the society and on the individual. At least 10 to 30% of patients presenting with angina have no significant coronary artery disease on invasive coronary angiography. And as many as 50 to 65% of these patients with chest pain without obstructive coronary artery disease are believed to have coronary microvascular dysfunction, also known as the microvascular angina. On the right side, if you see coronary artery disease, there is open artery, and when there is plaque buildup, the artery gets hardened, the it becomes narrowed. And on the microvascular disease, you see the open microvessels and then constricted microvessels. So historically, the only practical method available for the assessment of this coronary microvascular dysfunction have been invasive, such as the intracoronary Doppler flow wire or thermodilution. And this has likely impaired the objective evaluation of this entity in patients presenting with chest pain without obstructing coronary artery disease. Patient presenting with chest pain suggestive of any angina is taken to the cath lab, the coronary angiography is done, but that turns out to be normal anatomically. Thus, the treatment of this CMT has often been studied within imprecise clinical entities like cardiac syndrome X. A lack of consensus on diagnostic criteria and nomenclature for CMD has further obscured the evidence that sought to objectively define microvascular angina as a distinct clinical entity. And when we come to the etiologies of chest pain without obstructive coronary artery disease, this may be non-cardiac or it may be cardiac. Cardiac may again be non-ischemic or it may be ischemic. So non-cardiac chest pain, it may be because of pulmonary, musculoskeletal, gastrointestinal, even psychiatric and the smooth muscle dysfunctions. But when we talk of the cardiac, the non-ischemic or pericardial pain, the inappropriate pain perception by the patient, coronary spasm or the coronary vasospasm, atherosclerosis and inflammation, endothelial dysfunction, and the sympathetic dysfunction, they come under the cardiac ischemic entities. We can see that on coronary microvascular dysfunction, there may be cardiomyopathies. There may be heart failure with preserved ejection fraction, obstructive CAD, it may be iatrogenic because of embolization, increased sympathetic tone, acute coronary syndrome, then the Takotsubo syndrome and the angina. Now, look here, the non-cardiac 11%, mixed microvascular and vasospastic angina 21%, vasospastic angina 17%, but a good number of these patients, 51%, are because of the microvascular angina. So it is defined, as I told you, angina pectoris caused by abnormalities of the small coronary arteries. We see that the coronary artery supplies blood and oxygen to the heart muscles, the large coronary arteries, but this is a disease of the microcirculation leading to the heart muscles. The coronary macro and microcirculation, the microvascular angina endotypes, you see that there is structural endotypes and there is functional endotypes. Patient presenting clinically with microvascular angina could have similar manifestations to those with epicardial coronary artery disease, like angina, atypical angina, or the angina equivalent symptoms, and this is diagnosed clinically with particularly, especially listening to the patient's type of pain or type of presentation, and the clinician can very well clinically judge that, look, this is angina. Patients have effort-induced testosterone compressive chest pain or dyspnea, but sometimes symptoms can occur at rest during the night or when exercise is finished. There is a gender variation with a high prevalence of the condition in the females, especially the post-menopausal females. And these patients can have objective demonstration of myocardial ischemia, obtained with several tests like rest or stress electrocardiography, single photon emission computed tomography, the SPECT, the PET, cardiac magnetic resonance, CMR, or the stress echocardiography. Now, how to diagnose? The clinical characteristics and progression of patients with microvascular angina in an international and prospective cohort study by the Coronary Vasomotor Disorder International Study Group. The first international study provides novel evidence that microvascular angina is an important health problem regardless of the sex or the ethnicity, and that diagnosis portends a substantial risk for MASH associated with hypertension and previous history of CAD, and women have a lower quality of life than men despite the comparable prognosis. And this is the clinical criteria where there are symptoms of myocardial ischemia. They may be on effort or on rest angina, angina equivalent or shortness of the breath. Absence of obstructive CAD, less than 50% diameter reduction in the or FFR by more than 0.8 by coronary CTA and the invasive coronary angiography. Then the objective evidence of myocardial ischemia and evidence of impaired coronary microvascular function. The symptoms of myocardial ischemia, these are the diagnostic criteria: no obstructive coronary artery disease, objective evidence of myocardial ischemia, not mandatory, and evidence of impaired coronary microvascular functions. Now, the investigations in patients with suspected coronary microvascular angina, the ASC 2019, the recommendations are guide wire-based CFR and or microcirculatory resistance measurement should be considered in patients with persistent symptoms but coronary arteries that are either angiographically normal or have moderate stenosis with preserved IWFR or FFR. Class evidence is class 2A, level B. And intracoronary acetylcholine with ECG monitoring may be considered during angiography. But all these investigations, they are to be done in a specified higher center where cardiac patients are being looked after, and they are not to be done on any OPD basis in a small setup. These are the various non-invasive testing approaches to diagnose microvascular angina, like the cardiac PET, transthoracic Doppler contrast echo, CMR, and the cardiac CT, then the coronary function test, and they have got advantages and disadvantages. The invasive testing, confirmatory test to diagnose CMD, accurately identifies different pathways contributing to microvascular angina, carries a prognostication value and standardized protocol. But the disadvantages are there is radiation exposure, not widely available, risk of contrast-induced nephropathy in patients with renal failure, and requires complete preparation and hospitalization of the patient. This is the coronary function test preparation and protocol, which is done in a higher cardiac center. And the CMD pathway definitions in administration of different vasoactive substance is given here, which is again a very, very specific test. Prognosis, and in case 20% of the patient with microvascular angina experience a worsening of their symptoms with angina episodes, more frequent and prolonged, occurring sometimes at rest and difficult to handle clinically. Frequency and intensity of these episodes prompt frequent ambulatory visits, diagnostic, non-invasive and invasive testing, and even repeated hospital administrations. Patients' quality of life is negatively affected, making microvascular angina a significant condition from a personal, social, and economic perspective. Usually, the cardiologists, they go for the routine coronary angiography and the other tests, and if they found them normal, they say that no, this patient must be having some upper story problem. And in that certain cases, it is neglected, which happens to be very disastrous. Diabetes and microvascular angina, again, we all know that the endothelial function that is caused by diabetes in various vascular beds contributes to a wide range of complications and exerts unfavorable effect on the microcirculatory regulation also. And the coronary microcirculation precisely regulated through a number of interconnected physiological processes with the purpose of matching local blood flow to myocardial metabolic demands, and dysregulation of this network might contribute to varying degrees of pathological consequences. And this is the clinical progression of diabetes-induced adverse cardiac changes. No detectable cardiac changes like hyperglycemia, insulin resistance in diabetes. Subclinical level, when there is accelerated atherosclerotic changes, coronary microvascular dysfunction, cardiomyocyte changes ultimately leading to the ischemic heart disease, diabetic cardiomyopathy, and heart failure. Now, this is the proposed diagnostic therapeutic algorithm in these patients: subclinical disease, then the microvascular dysfunction, and CMP or heart failure. And step by step, we have to go for that and treat accordingly. Now, what is the pharmacological therapy? Pathophysiology-based approach to the treatment of patients with microvascular angina, we know that the impaired microvascular dilatation, reduced CFR, there is increased microvascular constriction, hyperreactivity to the constrictor stimuli. So, drugs reducing the oxygen consumption, the vasodilators, and the drugs reducing the visceral pain perception, they should be taken into account to treat microvascular angina. And various drugs available, statins alter the progression and even promote the regression of atherosclerosis and improve vascular endothelial function. They have powerful anti-inflammatory effect. In various pilot studies, atorvastatin improved the CFR at 2 and 6 months. And in systemic review, which is recently done, statins was associated with a significant improvement in the endothelial functions. ACE inhibitors, improvement of angina symptoms and CFR compared with the placebo group. And cardiac PET showed 42% improvement in their CFR, and studies have shown that benefits of ACE inhibitors are not limited to the objective measurement of CFT, endothelial dysfunction and symptoms, but extend to improvement in other circulating biomarkers. The antiplatelet agents, they prevent adverse outcomes in patients with microvascular angina. And the proposed mechanism is that TXA2 can cause arterial vasoconstriction, platelet aggregation, and vascular injury. So, inhibition of TXA2 pathway may prevent further microvascular damage. Beta blockers, of course, intracoronary nebuvolol was associated with a significant increase in CFR as well as a decrease in collateral blood flow index, and beta blockers increase diastolic coronary filling time and reduce the myocardial oxygen consumption. Calcium channel blockers, again, episodes of vasospasm and reducing cardiac afterload, they have a vasodilatory effect and they are associated with improved symptoms and the exercise tolerance. Nitrates can ameliorate anginal pain through venodilatation to reduce throughput load, but they do not have rapid or sufficient symptom relief in response to sublingual nitroglycerin, which is very, very important. So, other therapies are renologine, ivabradine, low-dose tricyclic antidepressant, abnormal cardiac nociception, aminophylline, mineralocorticoid inhibitors, phosphodiesterase esters, rokinase, inhibitors, L-arginine, sodium glucose cotransporter SGLT2 1 and 2 inhibitors, and the endothelial receptor agonist. Non-pharmacologic therapy exercise training is beneficial in stimulating nitric oxide pathway, which can result in exercise capacity with less anginal pain. Spinal cord stimulation improves anginal pain perception, and the enhanced external counter pulsation uses pneumatic cups applied to a patient's legs with simultaneous inflation and deflation synchronized to the cardiac cycle to improve the hemodynamics. So to conclude this, microvascular angina is frequent condition present in up to 40 to 50% of patients undergoing coronary angiography for angina and or positive ischemia test. Also associated with a poor cardiovascular prognosis and reduced quality of life, leading to increased pressure on the healthcare system, and patients with microvascular angina are at a high risk of MACE, including MI, stroke, heart failure with preserved ejection fraction, and death. Guidelines for diagnosis and management of patients with microvascular angina is still evolving. And I bring greetings from India, greetings from Innovative Physician Forum, and I invite you all for this Innovative Physician Forum's Medicon 2024 6th Annual Conference, which is organized by IPF Rajasthan Chapter at Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, the Pink City in Rajasthan. And this conference is going to be an international conference with UK and South Asian countries on 6th and 7th April, and most likely Sri Lanka College of Internal Medicine will also be a partner in this conference, and I invite you all for this. Thank you very much. Thank you, everyone.
Thank you very much, Professor Sharma, for the informative lecture. Now the time for the questions. I think we can incorporate few questions from the audience.
One thing I would like to tell that this entity, microvascular angina, is not being discussed on the platforms of internal medicine. Maybe the cardiologist might be discussing that at various cardiological conferences. So we must promote more of such topics, and I thank you, the organizers, the scientific chair, Dr. Suranga Malinga, for keeping this topic. Yes, sir.
Sir, I don't have any question, but only one comment to make, that it was an excellent presentation. Thank you very much for
Thank you,
this.
sir.
Is there any other questions?
Sir, may I ask a question?
Yes.
In Sri Lanka, I have noticed that a lot of cardiologists are very happy to prescribe ranlazine for ischemic pain, sometimes in favor of, I have not seen, maybe they have not added even beta blockers or calcium channel blockers. Is there any rationale behind this to so freely use ranlazine? Is it better?
In the year 2007, during the API conference, I think Dr. Jyotirmay Paul is here. He is the Dean of Indian College of Physicians. And the topic given to me was about ranelozine, because it is the drug which came at that time. Nowadays, if you see in refractory angina also, patient with all sorts of angina treatment, many of the cardiologists, they are writing ranelozine and other drugs also. We do not know what exactly it helps, but it has an effect, positive effect. Another drug is trimetazidine, which is also being written very frequently in these patients.
So in the absence of questions, we will conclude this lecture. Once again, thank you very much, sir.
Thank you, sir.
May I kindly invite Dr. Prasad Srivardhana to hand over the certificate of appreciation to Professor Sharma.
Thank you, everyone.